Dobar dan, Pavle me već predstavio, samo da evo naglasim koliko je zaista bitna, krucijalna ta povezanost između nas kliničara i ljudi koji rade na dijagnostici i koji rade na prevenciji, sve za dobrobiti pacijenta. A sad ću nastaviti na engleskom. Tick-borne encephalitis is a neglected zoonotic disease, neuroinvasive disease. It is caused by tick-borne encephalitis virus, which belongs to genus Flavivirus and family Flaviviridae. So this tick-borne encephalitis virus, it circulates inside its natural micro ecosystem, and it is spread by small mammals, which are reservoirs, and also hard ticks, which are having meals by them, who can be even vectors or reservoirs. So the most important tick-borne encephalitis virus vector in Europe is Ixodes ricinus. So humans are accidental hosts to tick-borne encephalitis virus, and most often they are exposed during the blood meal of infected tick. There is another way of transmission, so humans can get infected by consumption of contaminated milk or non-pasteurized dairy products, and this is the elementary type. So, according to phylogenetic clustering and geographical distributions, there are 5 main subtypes of tick-borne encephalitis virus, and they are classified as Western, Siberian, Far Eastern, Baikalian, and Himalayan. So, in most of European countries, this European type is dominant, but in some eastern part of European countries, this Far Eastern subtype could be found as well. Tick-borne encephalitis virus endemicity is recognized as a specific problem in Central European countries, which are near to us, such as Slovenia, Slovakia, Czech Republic, Austria, and Switzerland. So because of that, vaccination against tick-borne encephalitis virus can be or should be recommended to all residents, or maybe only to specific groups which are identified as risk groups because of tick-borne encephalitis exposure. So tick-borne encephalitis is recognized as a disease which is highly relevant to travel medicine, which refers to tourists visiting endemic countries. Speaking about Serbia, tick-borne encephalitis in Serbia is rarely reported, but maybe it's underreported, and it is neglected. Given that Ixodes ricinus ticks which were infected by tick-borne encephalitis virus were detected in several localities, such as Fruška Gora and Belgrade. So also another important thing is that tick-borne encephalitis virus was reported in patients who recovered from viral encephalitis of unknown origin, which we clinicians call encephalitis non-specificata. We know that we're talking about encephalitis in patients, but we do not the etiological diagnosis. So, or in patients who were previously infested by ticks. Talking about clinical presentation, tick-borne encephalitis virus infections is asymptomatic in most of the patients, or it could pass as a fever-like illness, but it could also progress in as severe inflammation of the central nervous system. So health practitioners in Serbia are most often not able to suspect or to recognize tick-borne encephalitis in patients who have non-specific viral encephalitis, because we do not have a uniform case definition on the country level, which we should have. And when we are talking about our patient, his health history started on 26 June 2022. He was a 58-year-old male who was living in South Serbia, and he was admitted to local hospital in northeast part of Switzerland in St. Gallen because he traveled there. And he presented with quadriparesis, impaired speech, increased body temperature, headache, malaise, muscle pain, and diarrheal syndrome. So he was visiting his family in this town of St. Gallen. He was there for 30 days. And he remembered having a tick bite 14 days ago. It was the 9th June 2022, while he was hiking in this forest area near St. Gallen with his grandchildren. And he reported that he removed the tick by himself using his fingers and discarded it afterwards. And he didn't go to doctors because of that. He denied existence of any comorbidity, as well as immunization against tick-borne encephalitis virus, which was logical because he was living in Serbia. And his disease was like this. First day of illness occurred approximately 7 days after the tick bite. He developed pain in lower back, some non-specific symptoms, headache, malaise, and increased body temperature, like a general infectious syndrome. And 7 days later, he started to feel weakness in his upper and lower extremities, and he had difficulties while speaking and swallowing. So this condition progressed until he developed breathing difficulties, and afterwards he was not able to talk, swallow, drink, stand, or walk. On the 10th day of illness, he was admitted to hospital because he developed the right-sided sensory and motor tetraparesis and hyporeflexia. He didn't have positive meningeal signs. And his swallowing, corneal, and coughing reflexes were preserved. So because of that, immediately after hospitalization to this clinic, the patient got intubated and mechanically ventilated due to respiratory insufficiency. And these are the preliminary lab results of the patient. We can see the 14th day of symptoms of the disease. As regarding to blood count, he had only slight leukocytosis with neutrophilia and slightly decreased lymphocytes. But talking about his cerebrospinal fluid analysis, he clearly had mixed pleocytosis, increased white cells in CSF, with neutrophils dominating, 55%, 24% of lymphocytes, and 21% of monocytes. And he had slightly increased protein level of CSF. So colleagues from Switzerland also performed the microbiologic analysis of CSF and blood. So they excluded potential infection by Borrelia burgdorferi, HIV, herpes simplex 1, 2, West Nile virus, syphilis, corona disease, etc. But they proved positivity of tick-borne encephalitis virus antibodies in IgM class. I also have to mention that they excluded autoimmune encephalitis and paraneoplastic encephalitis. And this is the MRI scan of the patient, which proved pretty progressive disease, because as you can see, the white arrows, they're showing that he had inflammation, clear inflammation in basal ganglia, putamen, nucleus caudatus, thalamus bilaterally. Also the inflammation of meninges and leptomeninges, and inflammation in parts of cervical and lumbosacral spine. 5 days later, which was the 19th day of disease, the patient was transferred to our clinic in Niš. We, of course, combined the anti-edematous therapy, which means mannitol solutions and corticosteroids. He also had physical therapy, anticoagulant therapy, nutritive therapy, which is not specific therapy, of course. And eventually, patient gained consciousness in a few days. He was able to understand and execute orders to open and close his eyes, but that was all. But his neurological condition stayed the same. So he still had quadriplegia, dysphagia, and aphasia. And he was subfebrile almost every day during his hospitalization in Switzerland, and he stayed this way in Serbia too. His EMNG tests were normal, so we excluded Guillain-Barré syndrome by that. And we we made a control MRI, which unfortunately stayed the same, no differences. The inflammation was in almost all the localizations like before with the same intensity. So he didn't make some neurological improvement at all. We repeated the CSF analysis, and on the 27th day of disease, his cytology and biochemical findings of CSF were unremarkable, which somebody could tell it was good, but still we noted the elevated protein levels, which were even more increased than before. And we wanted to prove that this IgM class positivity of tick-borne encephalitis virus is real, not just coincidence or false positivity. So we sent this CSF and serum to Pasteur Institute of Novi Sad, because it was the only location where we could perform those analyses. And we searched for detection of tick-borne encephalitis virus neutralizing antibodies. And we got this strong positive result. So both samples showed high neutralizing effect, which was suggesting acute tick-borne encephalitis infection. And this is the picture that colleagues who are microbiologists understand the most. But on the left side, you see the absence of antibodies, because you see the clear cytopathogenetic effect. On the right side, you see the clear cellular layer, healthy cellular layer, because virus is neutralized by patients' already formed antibodies. And this is the picture in color. So the green is the virus. So in the following period, the patient unfortunately didn't show any neurological improvement. He had the same degree of quadriparesis, and he even returned to the state of disturbed consciousness. And because he was too long in intensive care unit and being mechanically ventilated, his condition complicated by ventilatory associated pneumonia, which led to fatal outcome on the 60th day. So we should discuss this case a little bit. This infection of the patient occurred in June, which is in accordance to literature, because most of the infections do occur between June and August or October. His incubation time was 7 days, and this is the average incubation period in the literature. But he did develop neurological form, which happens in less than 10% of cases. So also very interesting that he had a complete clinical manifestation of tick-borne encephalitis infection in the form of encephalomyelitis, or I should say meningoencephalomyelitis, which happens in less than 10% of tick-borne encephalitis cases. So this patient was really unlucky. And talking about subtype, we can only suppose that the possible exposure was to the European subtype, because this happened in Switzerland, where fatal cases occur in less than 1 to 2% of cases. And he was among this 1 to 2% of cases. What is also in accordance with literature findings is that this happens mostly in older age and male gender, as in our patient. When we're talking about CSF findings, he had mixed phagocytosis and elevated proteins. And how to describe his elevation of liver enzymes, this happened because of maintenance of viremia. So he really did not have a chance to survive this, because virus was active. He had viremias for so long time. And MRI finding is also interesting, because it is talking about progressivity of this infection, because we noticed simultaneous involvement of meninges, leptomeninges, basal ganglia, thalamus, bilaterally meninges, and cervical and lumbar spinal cord, which could happen in 20 to 44%. So as a conclusion, I should say that because there is no available vaccine for tick-borne encephalitis in Serbia, this case of this patient is really highlighting the necessity for introduction of immunization against tick-borne encephalitis virus, because it is really neglected disease. I think that doctors even don't think about it. In South Serbia, they don't. Especially for persons who are traveling from Serbia to tick-borne encephalitis endemic territories. And Also, talking about vaccination in people who are staying in Serbia, I think that it should be expanded to population who are identified as population in greater risk for acquiring tick-borne encephalitis virus. So thank you for the attention. And I should say one more thing, that prevention is the best therapy. Thank you.